Hi, Roy. Welcome to Vitable's 5 Mile Difference, which comes from something that's quite personal to me and actually something that we both share in common. Where in Philadelphia, two zip codes just 5 miles apart, the average life expectancy difference can be upwards of 20 years. And, I've known you for the last few years, having worked with you closely as our board partner at First Round. And I often leave our conversations just more excited and to have the next one largely driven by the insights that you're and the depth of just context and empathy that you have to the problem. So welcome to the Vitables 5 Mile Difference, Roy.
Yeah, thanks for having me, Joe. It's always fun to talk to you.
Amazing. Well, maybe to start off, would love if you could give just a quick background on, you were the chief innovation officer at Penn right before you joined First Round as a board partner, and before that spent time at Intuit. But would love if you could give just a quick overview of how you ended up at Penn and then First Round.
Yeah, I had moved to Philadelphia all the way back in 2003, even though I was still flying back to California to work at Intuit every month or so. And did that for another 9 years. And some of the things that we were doing at Intuit really made me think about how they could be done in healthcare, even before I knew anything about healthcare. One of the main examples of that was some of the behavioral science work that we had started doing in healthcare. They were just so incredibly effective, right? When you understand that people make cognitive errors in decisions, or that you can influence the decisions and choices people make, it was sort of natural to start thinking about how you could do that in a nonprofit, social good type of context. That was in sort of the back of my head. But I also had started to talk to a friend of mine named Kevin Volpe, who is just an amazing physician and leader at Penn, who runs the largest institute for behavioral science in healthcare, and got to know some of the Penn leadership. And it was just an interesting moment in time. Zeke Emanuel had started talking about how are we going to fix this multi-trillion-dollar problem, and his answer was get people to be healthier, right? Which was interesting to me in that I always felt that healthcare was a mission-driven business for clinicians because you could help people, but that business people, our job was more like volume, and that wasn't as much of a mission-driven thing for me when you were in a fee-for-service world. And as soon as Zeke started explaining sort of the reality of what does it mean to get a population to be healthier, I realized that it's really making it a mission-driven business for everyone. There has to be an alignment end to end. Like you have to make money by doing the right thing. And so that was exciting to me. And that, around 2012, that got me really interested and got me thinking a lot more about joining healthcare.
And as you made the transition, what was that like? I'm imagining the world might have been quite different. What was that first year like, and what took a while to adjust?
So, I knew nothing, right? So I knew absolutely nothing about healthcare. And I was insanely lucky to be surrounded by doctors and nurses and administrators and other people on the care team that cared enough to say, we want to do things better and want to do things differently, right? There are just so many inspired people at Penn Medicine who said, I think we can do better. And they were willing to work with me and take my crazy ideas about methods and testing new things and experimenting with new things. And they, of course, educated me on healthcare. And I had a partner and a gentleman named Dr. David Ash, who's brilliant, and another partner, Dr. Siobhan Mehta, who is also brilliant, who were deeply trained. They were both Wharton MD, MBAs, and they were just exceptional at thinking about how do you do really hard things that involve lots of people, right? Change when it involves a lot of people is not an easy thing. And so I got trained by brilliant people, and it was different in that as you are thinking about innovating in healthcare, you do have to worry about harm differently. You do have to worry about decision making and even technology foundations and infrastructure differently. Decision making was harder, and maybe most of all, you don't control the revenue side, the pricing side, right? You kind of get paid based on things like negotiated reimbursement rates, and so you can't so easily snap your fingers and have something brand new. At least back then it was certainly harder. I started to find that innovating within business models could go a lot faster. If you wanted to get paid differently, that negotiation was possible, but took longer. So you had to say, boy, if I wait until I can completely and fundamentally change the way we get paid, that might be a multi-year process, and someone's going to run out of patience and say, we're not willing to wait anymore, and then you lose funding for your lab, your institute, and your work. So you have to sort of balance these sort of short-term and long-term goals if you're serious about driving outcomes. So that was different. You didn't control all the variables the way you did when you're in your own business, and particularly outside healthcare.
That's quite interesting. And maybe to take a step back, if you could help just paint the picture of how large was Penn Medicine. And when I think about innovation in the context of a health system, I can imagine just it being somewhat difficult to find the narrow scope to start. And I think one of the things that you've mentioned in previous conversations is how you set up quick experiments to to optimize for the pace of learning. So maybe to start, if you could give just a quick overview of how large the Penn Medicine was, and where did you initially focus?
So there's a couple different answers to that question. So Penn Medicine is huge. Without getting into the details, I mean, there's already many hospitals, tens of thousands of employees. It's an academic medical center. We have inpatient, we have outpatient, we have home care. It is a extraordinarily complex organization. And there were a few things going on. We were at the beginning of taking on some risk. For example, readmission penalties, and giving a place like Independence Blue Cross a readmission warranty. We're now saying, okay, we'll be responsible if somebody comes back to the hospital after being discharged. We're on the hook. You don't get paid again if they end up back in the hospital. So that was an interesting sort of toehold, a place to start. Our employee base was an interesting place to start, and there's a story behind that as well. In that David and Siobhan, the partners I talked about, we sort of knew we had to get some points on the board relatively quickly, and they were able to do what I thought was just fascinating work, using back to the behavioral science idea about keeping people in system, right, where you're paying sort of wholesale instead of retail, keeping people in for imaging or for pharmacy. And by doing some design work, they were able to help our benefits team save a tremendous amount of money. Now, it wasn't the change the world and improve longevity and reduce suffering. It wasn't all the things that we hoped to do ultimately, but it was some very quick points on the board, and it showed that some of these methods could really make a big difference relatively quickly. So that was one answer to how do you get started. You find something you can do well and you can do fast, and it's almost like there's a theory of quick wins or small wins. And that was part of the thinking. I think, we're always talking to the executive team about what their priorities were. And then you're always talking to the front line. You're just kind of walking around getting to meet all the different departments. You have all the departments that any academic medical center has, as well as sort of there's the frontline clinicians and others, the COOs and everybody, to say, like, what are you wrestling with? And also, what are your insights? Because a lot of these people had brilliant insights. They just weren't quite sure how to get started, right? And so if you take their insights and their knowledge and our ability to get things started, we had a few really nice assets and some lucky assets. So we had engineers who could build stuff. We had a platform that David and Kevin Volk had built called Way to Health, which automated communications, two-way automated communications, that we could do an awful lot with. We had designers. We had some sort of preferential ability to get things staffed in the IS department. So we also just had this fundamental belief that change was possible. And there's a lot of people who will, I think, agree with the statement, optimism wins. And you've heard this statement, optimism wins, from others who think about driving difficult change. And I think that we would take some of these insights and some of these just forward-leaning clinicians and say, your insight is a great one. That's possible. Let's figure out how to do something quickly to demonstrate that it actually would change the world. Like, let's work with 5 patients or 1 unit or 1 practice for 5 days or 3 weeks, whatever it was, in these small snippets of time, and say, hey, let's actually try it and show that something here would make a real difference. And you get even small amounts of data, and then confidence builds, right? You can, oh wow, look at that, let's do more, right? And so it's very hypothesis driven. It was very reliant on these methods of rapid experimentation, but you had a willing group of people who wanted change, who were mission driven. They wanted better outcomes for everybody. You had a supportive, executive team who was willing to fund some of this work, and you had an extraordinary variety of settings in which you could test new things. Again, inpatient, outpatient, this community, that community, all kind of different ways that you could try things. So you work across every division and department you can imagine, in every care setting you can imagine, and you start to just learn that, it is hard to change healthcare, but it is also possible, right? Change is definitely possible. And there's just tremendous complexity underneath it that we can get into if you want, but it is definitely possible.
And what was the most impactful thing that you worked on during that time when you think back to those early years?
It would be hard to pick one thing out. I think in the end we ended up designing and implementing 150 or so interventions, and incubated companies along the way as well. And the one that a lot of people talk about, which maybe talked about largely because it was easy to measure the impact for good, was a project called Heart Safe Motherhood, which has gotten some coverage already, in that Sindhu Srinivasan and Adi Hirschberg were our clinical partners in the women's health world. And this problem got brought to us that you had a rising maternal morbidity and mortality, and lots of attempts to change that, and nothing was really working. And one of the big drivers was preeclampsia, right? Hypertension related to pregnancy. And it was driving 20% of mortality, a third of your readmissions and morbidity incidents. And nothing was working all that well. And to engage with that team on what's really going on here and how do we change it, allowed us to do some of these rapid experimentation methods, allowed us to intervene, sending women home with blood pressure cuffs, teaching them how to take their blood pressure. We knew from earlier studies that if we understood what their blood pressure was after discharge and could act on that information, deliver medications, have them take the medications, we could avoid most of the incidents of bad outcomes. And by doing so, we ended up in the we here, I give tons of credit to Sindhu and Adi, two physicians around the team, as well as the Way to Health, again, the automation technology platform team. But we were able to eliminate 80% of morbidity and readmissions, 80%, right? That's an enormous difference. So you can start to count the number of strokes that new mothers did not have, the number of deaths that did not happen. And you can start to engage partners like Blue Cross to say, hey, we can deliver care fundamentally differently. This became a national best practice and evolved well beyond Penn to other health systems as well. And I think like those are the types of examples that get people really excited. But it's funny, given that I'm talking to you on a podcast called The 5 Mile Difference, when I look at that list of 150 different interventions, one of the ones that of course is has a very high profile in my memory is the work that Shreya Kangovi led. And she was one of the first faculty members that I worked with. And it's an interesting thing because when you go back in history, some of the things that might be more obvious now were really surprising then, right? Because you're rewinding the tapes, right? And I remember when I first started talking to Shreya back in 2012, she had this absolute belief that she could address social determinants of health, right? And that she could take essentially the foundation of a care model, which was a community health worker, based model, and completely reimagine it in a way to make it evidence-based and effective and scalable and spreadable in a way that it never had been before. And so at the time, there were a lot of people who said, well, that's not really the job of the hospital. How can hospitals and health systems take on food insecurity and housing insecurity and addiction and abuse and these things that are societal ills and societal problems and policy-based problems? Like hospitals have a hard enough time taking care of health, right? And all of that was true. But Shreya being Shreya, was incredibly committed and incredibly passionate about this, and just continued to iterate the way a lot of entrepreneurs that you and I know just naturally iterate, try and iterate and try and iterate and learn and iterate. And, across multiple RCTs, right, randomized controlled trials, where she's really testing and proving things with validity, right, gold standard validity, she showed that she could absolutely do it. Now, she had to reimagine every part of this intervention, from how do you identify the community health worker, and how do you, recruit them and train them and onboard them and deploy them and manage them and evaluate them, and track over time, like, and adjust. Every single part changed. But here you have an intervention now that has eliminated more than half of hospital days, right? Her net savings per person was over $2,500 per person per year. And you have sort of political parties who are moving the deck chairs on the Titanic and debating, policies that don't fundamentally reduce suffering and reduce misery and improve outcomes and save money. And here you have these interventions that actually do those things. Shreya has now spread that across more than 20 states. She has, more than 50 enterprise clients last time I checked in with her. And she is again and again showing that she can replicate it. She replicated it recently in a rural setting. Again, a very difficult thing to do, right? And so, these interventions and this way of saying, I see the problem, I understand the root cause of the problem, and I am just going to keep going after that problem until I solve it. It takes a real entrepreneur. She's a faculty member who became an entrepreneur and spun that company out, and is growing that company as the CEO now. And it's wonderful to see. That was one of the programs that we helped with in the Innovation Center at Penn.
That's actually fascinating to hear. I suppose imagining you've seen things work really well, but you've also seen things maybe not work out as expected. When things were within your control, within the control of the person driving them, what were some of the more common mistakes that, maybe preventable mistakes that you've seen occur that future builders and entrepreneurs maybe could avoid?
Yeah, we definitely made our share of mistakes, and there's quite a few different flavors of it. They ranged from getting really excited about a problem without doing rigorous opportunity sizing, and only later realizing that it was a critical problem for the people you wanted to help, but it really maybe wasn't representative, and it wasn't a big problem for the system, right? That was one flavor I can imagine. We learned a lot of tough lessons around stakeholder management, right? The number of different people you needed to have engaged. You couldn't just have a clinical champion without an executive champion. You couldn't just have an executive champion without a clinical champion and an engaged care team to start with, right? You needed a setting, you needed people and patients and access. You needed data, right? You needed, if you don't have good access to sort of the information you need to work with, that obviously gets in the way. These things are all so obvious. And yet, you can fall in love with these problems and not be set up for success because you don't have the right levels of access or support, of obstacle clearance, obstacle removal that you need. And so, a lot of times in health systems, you need to have what some people at least call these multi-threaded, kind of engagements. You have to have multiple people excited on the IS side, on the finance side, on the clinical side, on the, the ops side, the whole thing, right? And so we learned some tough lessons on how do you make sure that you have all those people engaged. We didn't always get successful on like helping people reimagine how to think about accounting and economics too. Like some things stayed in silos. So, you're working with an intervention that is across the traditional silos. If you have inpatient, you have outpatient, you have home care. Maybe you have an intervention where one of them gets much better. Inpatient gets much better, and maybe home care gets a little worse. And you could easily balance across that silos. You take 2 units away from the hospital and, add a couple of those units over and a transfer to home care. We didn't always get that right, where you could work outside and across silos really effectively. But again, I think that comes back to really good stakeholder engagement. And I think some of that is how you tell stories, right? There's this combination of data and storytelling. You do need executives to feel it and see it themselves. Like you have to build empathy. They have to want to solve these problems, which means often connecting them directly to the problem so they can see and feel it themselves. I don't know that we always did that as well as we could have. And when we used data, which I think we did pretty effectively, sometimes we didn't tell the scaled version, like, hey, look what we did. We worked with these 20 people and we kept 14 of them out of the emergency room, right? If you're managing a multi-billion-dollar health system, that's immaterial. But like if you scale that up to say, this would actually save $60 million a year and keep, 17,000 people out if we scaled and if we were able to maintain these results at scale. So you're not presenting the results at scale. And that's another, pothole, right? You're saying, here's what I did and look how well it worked in this small experiment. But the goal is not the small experiment. The goal is scaled impact. It's always scaled impact, right? And I could unfortunately go on because this is a complex environment where when you're trying to drive change is hard. And sometimes you even need to create new ways of measuring things that don't exist, right? You need to be able to measure something that hasn't been measured before. And so those are hard. And I need to measure backfill. Like I'm going to get somebody out of a hospital bed. You get paid to have someone in a hospital bed. How do I measure and how do I expect what happens to that hospital bed when I open it up? Who occupies that? How often is it occupied, right? So you have to like build models sometimes that are quite hard to build and sometimes require trying it and doing it until you know what reality is going to be.
What you're describing sounds like an even more pronounced version of the innovator's dilemma. Is disruptive innovation possible in healthcare, or is it you have to work within the system to move the needle?
No, I actually spent a long time believing disruptive innovation was not possible in healthcare, and I'm changing my mind now. So you and I have talked about this. I knew Clay, and Clay disruptive innovation in part was that theory was built based on Intuit, my last company, and sort of our ability. We were one of the few serial disruptors, which we didn't do knowingly, right? Like the theory of disruption was described after we did it, using us as an input to that theory. We just happened to work in a way, and Clay was brilliant at pattern matching and saying, hey, this is a repeatable way of thinking about how new entrants are more likely to win, versus existing competitors. But a lot of those dynamics didn't really hold in healthcare, that for all kinds of reasons, that ranged from licensing control to lots of other things, to the inability to control business models and pricing to lots of stuff, and you saw this many, many years of consolidation. I mean, it's still going on, right? The big systems, the big players buying the small ones and buying them up. And, the old strategies haven't changed that much, right? Get more scale so you have more negotiating leverage against the insurance company or vice versa, so you can negotiate better contract rates. That's one strategy. I mean, I don't think it's a very creative strategy, but it actually still works, right? More scale gives you more leverage. And where you have less competition in certain geographic areas nationally, there's a direct correlation with the margins of those health systems. People are like, I'm scrapping for a 2% margin where I have this competition. And look at those guys. They have a 12, 15% margin, that's because it's a competition difference. So lately, one of the things that's been changing my belief is that as I see the onset of AI and what's really possible because of it, so not all the hype around AI, but the reality of AI, what I'm actually seeing in terms of automation. Let's even just talk on the administrative side, right? One of the reasons doctors were selling is that the administrative and bureaucratic burdens were massive, right? Like to run your office, to deal with the EMRs, to do all the things that you had to do on the billing and RCM sides. It was just an extraordinary burden. Like you couldn't just be a doctor, be a nurse and see patients and treat patients and, enjoy making a difference every day. I mean, you were running a business, and that's as regulations increased and those regulatory burdens increased, it was quite a load. The more I see that becoming automated and simpler, the more excited I get, because it actually is, it's related to your question about disruption. It's actually enabling more of the smaller players to stay in business and be competitive. Right? We get stories from companies that are using, first round companies. One that I've been quoting a lot lately is Brellium. I think Zach and the Brellium team. Where we get a letter, from someone who they have to do chart review. It's a behavioral health company, and they have to do chart review for payer and quality compliance. And they were going to hire 9 people, and they used Brilliant instead. They saved $600,000 a year. And sometimes, the ability to not hire those 9 people and save $600,000 a year means you're now in business instead of being out of business or having to sell to one of the big health systems, right? To just continue that pattern of consolidation. So that's just one of many, many examples. And you and I know have talked about some others in the past, but like the more I see the ability of the smaller players to compete and to stay in business and to be profitable and to focus on delivering better care with better margin, right? Even in the face of all the complexity that still exists, because the technology is taking more of it over, the more I start to believe that disruption may be possible now in this industry in ways that I don't think it was before, right? Because the fundamental litmus test still hold, right? Disruption is from this ability, you have new market, you have low end disruption, 2 flavors of disruption, but you have these kind of litmus tests of where are people outsourcing due to lack of skill or expertise, and all these other ways of testing, is this a disruptive opportunity? And many of them hold in healthcare. It just wasn't possible for new entrants to kind of break through and to sustain when they didn't control some of the other elements about complexity and getting paid.
And you see with the AI platform shift, this is finally creating the opportunity for new entrants to break through.
Absolutely. I mean, just another example. The Assort team, John and Jeff. Some of their recent numbers when they're automating all the handling of all the incoming calls, you're seeing a 50 to 60% reduction in FTE cost, right? 50 to 60% reduction in FTE costs. That's incredible. And that's before you even get to the fact that because there's no missed calls, there's no drop calls, there's no wait times, you're triaging appropriately and you're converting all this stuff, you're seeing a 3, 4, 5% increase in revenue. Sounds small, 3, 4, 5%, but if you do the math on the volume of calls coming to practice, $1.5, $2 million of additional revenue while you're bringing your costs down. So was that possible a couple years ago? No, right? So now all of a sudden you have an entrant who can stay in business, right? Where they couldn't have stayed in business before. So I do get really excited about, those type of things and those type of opportunities. Even like, one of the newer ones, I don't know if you've met Lava at Corner Health, but this is my term, not her term. She may not like the way I describe it, but like she's building a full technology stack. It's like a business in a box. But the reason I use that term is like you can hand nurse practitioners a piece of, not a piece of software, a tech stack, but business in a box, which allows them to create a primary care practice where they wouldn't be able to go into business and to compete in that market and to increase access to primary care. So like, one of the things I love about you, Joe, right? You increase access to primary care. And by not just increasing access, but doing it well, and we can talk about that, you at Vitable, you've shown that you can bring down the total cost of care for employers, right? That's fantastic. But, we don't have enough access to primary care. So now Lava with the technology stack, she means NPs can now go into business and create access to primary care that in many markets would not have otherwise existed, right? So, I get excited because the technology is allowing humans to do what humans can do, right? Not because the technology is replacing the humans.
And right before this, that reminded me, you'd mentioned call it telehealth 1.0, but are we still in the telehealth 1.0, or, as you see it, what is that next iteration that lives up and fully takes advantage of the medium?
Yeah. I mean, so just to give people listening a quick, snapshot of what you and I are talking about, what you're referencing. So we were talking about platform shifts, right? And platform shifts, what the Intuit team is to talk about is whenever there's a platform shift, the first thing you end up seeing is people doing things the old way on the new platform. And it's really not that exciting, but people haven't yet imagined what's possible on the new platform. So the example that we used to use was when it went from radio to television. What you would see is an announcer was on television just talking into a microphone. So they're basically doing radio on TV. They weren't taking advantage of any of the new media capabilities. It was just a radio announcer on camera with a visual, right? Until people figured out what was actually possible using this different visual, and recording medium. And so you've seen that with the internet, you've seen that with mobile. Every time you don't fully appreciate what's possible right out of the gate. And Joe, I think what you're referencing is when virtual care and telehealth became possible, there was this excitement of, oh wow, technology, I can move those things that were offline online, just like move the things that were, in the first wave of the internet, move businesses that were offline, now move them online. But you haven't added enough value at that point just by moving the offline online, because you haven't yet taken full advantage of the capabilities of the new platform. And so I don't think we're in 1.0 anymore, because a lot of the 1.0s just didn't make it, right? They didn't prove that they could do anything really valuable, right? They didn't show that they could fundamentally change anything. And so you saw areas that were really crowded now get less crowded. I look at, what Stephanie has built in Boulder Care, and it was so saturated, but most of them didn't make this fundamental difference. Like she's showing, okay, I have an 80% reduction in mortality, and I'm eliminating half of hospitalizations, 50% of hospitalizations. Like, so she's using access in the medium and efficiency and technology. They basically have like 100% utilization. They're using this differently to deliver a different level of results, right? And, I see you doing that. I see Pomelo doing that. I see Ansible doing that. So the companies that are still around and performing have moved past that 1.0 of just take the things that were offline and move them online. Hey, look, we have virtual care. Like it's got to be more than that to be an exciting opportunity, And I think I made the point to you that it's not that 1.0 is bad in any way, right? Like you get a lot of things by default without adding a lot of value, like convenience. Now I can sit in my living room. I don't have transportation. I can still get care. You didn't have to be creative. Just Zoom alone or FaceTime allows you to do that, right? You didn't add value on top of the tech change itself. You just took advantage of the tech change. But again, that's still in the 1.0. So it's that next level that starts to get really, really interesting. What can I automate? What else changes because I now have data I never had before? Like, oh, wait, I can get ahead of this problem. I can see a problem developing and I can actually intervene before that person gets to the emergency room. Hey, that's actually really interesting. Now I've avoided the cost. I haven't just dealt with a problem when that problem comes up.
On that note, actually, in previous conversations, we've talked a lot about behavioral economics and how it could be used to increase both utilization and drive better outcomes, especially in communities with low trust in the system. For operators building, what are one or two behavioral design ideas that you found to generally work that other healthcare operators should know?
You don't have to get too fancy to get into a realm that is insanely effective. A good example is defaults, right? So I think a lot of behavioral sciences is friction management, right? People do the least amount of effort possible. So if you think about the world in terms of friction, and there are different paths people can go down, if you're taking friction away from one path that you want people to follow and adding friction to other paths that maybe you don't want people to follow, you're going to change behavior, right? And I think that like the first intervention that actually was the genesis of the nudge unit at Penn became an episode of Freakonomics. And the title of the episode is How Do You Save $32 million in an Hour? Which is what happened. It was a $32 million savings in an hour. And it was a default type of design. And I see this all over the place. So default is, if I take no action, what happens, right? So instead of an opt-in, I have to decide to do something. Default might be like, I have to take an action to not do that thing, right? So there's more friction in terms of not doing the good thing, right? And there's also a social norming aspect of like, wow, if that's the default, that must be what I'm supposed to do. That must be what other people also do. So I want to do what most people do. And that's sort of this implicit way that human brains function as well, right? So, in the case of designing interventions, think of it this way. I'll use a sort of disguised real version, right? Because I don't want to give away something that's confidential from one of the companies. But imagine you're a service provider. You're doing care delivery services, right? And you you have a patient population that you want to serve, right? And that patient population comes from somewhere else. You know, in your case, it might come from an employer. In another case, the case that I'm actually thinking about, it might come from a payer. Here's a panel of patients, a patient population that meets certain criteria, and I'd like you to take care of them. You know, and often this is a kind of go hunting. You know, here are 10,000 patients, and you get paid for the ones that you can engage, right? There's a lot of different ways to do that, right? You know, you could call them and email them and try to convince them to sign up and enroll in the service. You know, that's one way you could do it. Or it could be a default where they're in the service by default, right? Unless they choose to opt out and not be in the service, right? Let's say it's a referral from a provider, from a health system, right? So either the provider or the care team has to think about it and say, oh, Joe, you know, Joe probably qualifies to the service. Like, oh, this service would be good for Joe. I should enroll Joe in this service, right? That's an opt-in. That's friction. There's effort. There's remembering. There's actions that are required, right? But if it was a default, like even if a lot of that work was done in an order set, even if it wasn't all the way to a default, and like basically it's on the screen, it's like, oh, no, Joe's actually signed up unless I decide not to do it. Like Joe meets the criteria and Joe should be in the service. And actually all the work was automated to put Joe in the service. And now as the clinician, I can say, no, I don't agree with that. I'm going to take Joe out of the service. That would be this idea of moving from opt-in to opt-out. And you're going to have a tremendously bigger opportunity in the opt-out world, right? You know, the work is gone, the thinking is gone. The default is that they're enrolled in your service. You're going to have a higher conversion rate. You're going to pick up a lot more people that you can serve on that second design rather than the original design of, oh, somebody has to think about this. Somebody has to do the work. Somebody has to do the enrollment. Somebody has to place the order. Somebody has to do all these things. Each effort is a barrier. Every time you have to lift a finger, every time you have to fill out a form, every time you have to stop and think about something when you're a really busy person, each one of those reduces conversion rates, right? So default to the behavior, the action you want instead of, you know, having to make it happen. That's a good example of using behavioral science for a business outcome.
Well, as you were speaking, it reminded me of the shift in 401ks from opt out to being opt in, and the increase in adoption for employees. How much of this should be driven by regulation versus by operators innovating and testing? And maybe this is a broader question about if you had a magic wand, what type of healthcare system would you design?
Yeah. So I would have said, a while back that I am wary of regulation and policy. And I think that I'm more of a micro person than a macro person. I think when you spend time in the industry trying to drive change, you realize that you need policy as a big lever, right? Like until you align incentives, for example, it's really hard to motivate the right behaviors, right? When you move to a global payment, for 90 days around a surgery, there's a completely different incentive for health systems around, keeping that person at home and not bringing them back for multiple appointments. They probably need the service and the care that they get in those appointments, but they don't actually need the appointment, right? And my team at Penn took advantage of that change in policy to redesign care. And this is a woman named Kat Lee in the plastic surgery group around breast reconstruction. They were able to eliminate 3 out of 5 follow-up appointments when the way you get paid changes, which is a policy change, right? And and what does that do? Well, that opens up access to other people who need to get in fast because they might have breast cancer. So it's really, these things really matter. And like, if you don't have the right policy, it's very hard to innovate. If you see what's going on the big, not so beautiful bill right now, right? I mean, like if you end up kicking 10, 11 million people off of Medicaid and they don't have access to care, we already know what happens, even if it's done through work requirements, right? Because work requirements don't work. And anyone who's studied Arkansas or any of the prior data know that the people who end up losing insurance and therefore losing care are already working, right? It's actually not a work requirement, it's a paperwork requirement. I mean, that's really what it is, right? And so by failing to accomplish the paperwork, you end up harming the people that you don't intend to harm, right? There was no gain in employment, right? Arkansas is a great example. Work requirements do not improve or increase employment. They simply harm people. So you end up with a lot more premature death. Back to 5 mile difference. You're just going to end up with more premature death and a bigger gap between haves and have-nots. And so how much do I think that regulation and policy matter? A lot. And, because then people can innovate inside of those policies. But we have a lot of companies, you included, who are doing incredible work to help vulnerable populations. And if there is no funding available to help vulnerable populations, it gets harder for the people who say, you know what, I'm not going to go after the wealthiest people. I'm going to go after helping people who need the help. There's a way for me to get paid, and I can innovate on making it super efficient and super effective. But there's at least a foundation, there's fertile soil. Somebody cares enough to create an opportunity that I can build a business helping people who need help, right? And so, yeah, you can't ignore the macro policy environment, because that just makes it too hard, no matter how innovative or entrepreneurial, this country is. And this country, I've never lost faith in our ability to be massively entrepreneurial and innovative. You still need the right policies for incentive alignment.
You mentioned the one big beautiful bill. In most other industries, innovation comes first and then regulation maybe follows. Whereas in healthcare, regulation comes first and then innovation follows.
Yeah.
But the shifting goalposts can hinder the amount of both just willingness to innovate within healthcare and also attracting the brightest people, maybe.
Yeah.
If it and like as the example that came to mind was a dual, there's a lot of innovation or companies built around the dual eligibles, and now with and also just there was an increase of innovation targeted towards the Medicaid population, but with the one big beautiful or maybe not so beautiful bill, the number of enrollees into Medicaid would be substantially reduced, and it introduces ambiguity, and that maybe isn't so great for operators. Is there any way around it, or what should operators do if you're building for these populations, given the ambiguity, the regulatory ambiguity?
So, as a lot of pundits, including my friend Zeke Emanuel, often say, like, you can only control what you can control. And I think that the fact that you and others serving this population are much more efficient than other ways that states and payers and others end up spending money, you take advantage of your advantages, right? And you have to be very strong and loud and saying, look, you still have to get certain things done. You still have to address health problems that exist in the world. And I'm going to lean into what I'm best at. Like, okay, you need to take care of that patient population or this addiction problem or this, maternal health problem. I'm the best way you can possibly do it, because if you have to make every dollar go farther, because you're going to end up having to stretch dollars, these more technology enabled ways of doing that are going to win out, right? And so, but you have to very vocally make that case that if you need to make every dollar stretch a lot farther, then I'm the way, I'm the partner for you, and sort of get in front of the government agencies, the risk-bearing entities, right, in these cases. So, there's lobbying efforts. I mean, I do think that it's really important to be vocal with lawmakers and policymakers. It's maybe it's too late in this round, but it's never too late, right? Democracy is an unfolding process. So I think that there will be damage if this bill, passes. People will be affected. A lot of the people affected are the ones who are counting on their Republican legislators to take care of them. Those people have violated that trust, I think. And, it's a shame to be political on a podcast like this, but if you don't think about it as political and you think about it as, are you doing good and creating value in the world? Or are you doing harm and destroying value in the world? I mean, there's value destruction going on, right? Let alone actual human suffering and harm. So, I think that lobbying and being politically active and being vocal to help other people understand that this is not waste, that there are not all these people sitting around collecting benefits without working. Like, that's just a myth. It's false, right? All the way back to the welfare queen story, that was circulating in decades ago. These things, they loom large in sort of the public imagination, but they're not representative of reality. And so, our biggest issue today, I think, is misinformation and disinformation, because the things that people have to believe to support these policies is just a different set of facts. So I do think that being part of the clear communication about reality is also important.
With the One Big Beautiful Bill, I was rereading Only the Paranoid Survive. And one of the things that it talks about is how regulation is often one of the, similar to technology platform shifts, regulation can oftentimes be as powerful. And what you're describing seems to be that, digital health companies can actually provide value, and as opposed to this, instead of this being quite disruptive for them, it could be an opportunity for these models to actually accelerate their adoption, improve the effectiveness
Yeah.
while meeting the budgetary constraints.
Yeah, I mean, sadly, right? Sometimes it takes a crisis to create change. This is a crisis. I mean, we got an unbelievable amount done during COVID. Now, COVID was a terrible, horrible thing, but it produced a lot of really great value because it was a crisis, and people relaxed governance committees and relaxed the number of permissions you needed to get stuff done, and at least paid attention and said, "Oh my God, I need a solution, and I need a solution yesterday." Right. So yeah, never let a good crisis go wasted. But there's certainly a part to that. But Joe, I do want to just, for 1 minute, maybe pick on one thing you said, that it's not always that regulation drives innovation. Sometimes it is the other way around in healthcare too. I mean, you are seeing companies produce data on a new intervention that then change policy, right? And so this is not just, CMS innovation demonstration projects and stuff, but startups and independent companies are often like getting started under maybe the old model, like a fee-for-service model in some area of healthcare, producing data and then going back to the risk-bearing entities and saying, hey, look what we can do. Look what happened. You should actually work with us to get to a different model, a different policy here. And that happens. The problem is that it takes years sometimes, right? Not that it doesn't happen, but I just wanted to point out it does go both ways. It does go both ways. There are people who are out innovating, saying, I can change this, give me a chance, and I'll show you the data, and then we'll work together to change it. That definitely happens, but it just takes time.
Right. Thank you for that clarification. Is there an example that comes to mind?
We were able to do it with some of the cases back at Penn, even on the Heart Safe Motherhood case of showing, Blue Cross, for example, how many people we were able to keep out of the hospital and what that would mean for them in terms of total cost of care, and what it would cost us to run that program really effectively. And if they wanted us to do it, to eliminate 80% of readmissions and 80% of morbidity, here's what it would take. So there are conversations like that. I mean, there's one recently, again, I won't name the place, but there was an intervention about keeping a certain patient population out of the emergency room. And it was a more involved intervention in terms of what it took to deliver this intervention. So it was too costly for the existing payment mechanisms. And by producing data and running those rapid experiments I talked about earlier, and going back and sharing all that data and engaging in conversations and painting the right picture, again, not just what the intervention did, but looking at the counterfactual, right? That is hard to see sometimes. Because if you don't do this new intervention, this many people are going to end up in the emergency room. This many people are going to end up getting admitted. They're going to stay in the hospital for this long at this total cost, right? Or this intervention can avoid those things. But, you can't, normally that would be like a home care visit. And I can't do it under the normal payment model of a home care visit. So I would need you to at least support this type of investment in this area. So that kind of conversation does happen, and it can get to an agreement to say, okay, we're going to pay you differently because I understand the complete total picture now of economics. And ultimately, logic and rationality hopefully prevail.
Amazing. And maybe with a quick pivot back closer to home, with the healthcare landscape in Philadelphia has evolved quite a bit over the last decade. And more recently, with Crozier Hospital in Delaware County shutting down, I'm curious to get your perspective on, one, in the time that you were at Penn Medicine, what were the biggest shifts that you saw happening, locally, and maybe with the Crozier Hospital closing, curious to get your perspective on the impact that it will have.
Yeah, it's outside my area of expertise, I have to say, Joe. But like, there's a few things that are just logical and rational, and you saw some of this with Hahnemann. You saw what would have happened if Mercy had closed in West Philadelphia, which I think was pretty obvious to a lot of people paying attention in the city. When these hospitals close, those people have to go somewhere, right? And if you go back to the behavioral science piece, which wasn't my intent, it's not the first thing that popped into my head, but it just did, so I'll say it. If you go back to the point on friction, when you don't have convenient care, you delay care, right? It's a harder thing, like a longer ride to receive care or more effort to get to care is friction. And that means that worse access turns into worse outcomes almost every time. So in terms of what I think happens, it puts stress on the rest of the system. And those things can become sort of dominoes, sometimes when the remaining institutions have to pick up things when they're already over capacity. You have a lot of emergency rooms that are already on divert, the hospitals are already full. And, there's sort of this supply demand problem of there's more sick people than capacity. And so you need different ways of taking care of populations. And every time one of the one of the soldiers falls, if you will, it weakens the system. I'm sad to see that there is sort of a shift, it's kind of a squeeze the balloon type of thing. There's a certain amount of air in the balloon. And just because you squeeze here, the total amount of air doesn't change. It just moves to a different part of the balloon. I think you're going to see that in Philadelphia, and you're going to see new stresses, and you're going to see a widening of outcome gaps, from people who now don't have the resources to overcome the friction. Because when you have resources and you have money, overcoming friction, whether it's because you have a car and transportation or whether you have a job, you can take more time off to get to a different place or whatever those resources are, you're going to do better. So the more friction, the more likely that people with resources do remarkably better than people without resources. The less the friction, and I think this was part of Heart Safe Motherhood, right? You reduce friction because now you didn't have to go in even to a free walk-in clinic. You didn't have to leave your house. You didn't have to leave your job. We could find out about elevated blood pressures without any inconvenience, without childcare, without transportation. And so one of the most remarkable or surprising outcomes we saw from Heart Safe Motherhood was it actually eliminated a long-standing racial gap in outcomes, which, by the way, wasn't even the original intent, right? The original intent was to reduce morbidity readmissions for all women, not particularly to help Black women more than white women, just to improve morbidity and outcomes, right? And it ended up closing the gap between white women and Black women, which is just a proxy for resourcing in Philadelphia, right? And so when you see that because of a SES, socioeconomic difference, if you can remove friction, you will also reduce the 5 mile difference. You will reduce the gaps.
Thank you for spending the last hour or so with me, Roy. Last bit of questions. Healthcare is quite personal and local. And I'm curious, throughout your time, is there one story that comes to mind that just helped emphasize the impact that operators and individuals can have if they're willing to take on the complexity of the healthcare system?
I think the stories I've mentioned are certainly top of mind, right? The getting rid of lots of follow-up appointments, the Heart Safe Motherhood, getting rid of the disparity and the morbidity related to preeclampsia, and obviously Shreya Kangovi's work on community health workers. Those are all top of mind, but there are so many more where, Joe, I guess I would say that every time you had committed, mission-driven innovators and a supportive administrative team, you could get a great outcome because there is low-hanging fruit. I mean, there's just kind of inefficiency in some ways built in to the current way of doing things in healthcare. So smart people, particularly smart people leveraging technology, if they have a supportive environment, they're going to make an enormous difference. I mean, I remember there was a series of projects where we were, I think I mentioned, working on readmissions because there was now this financial incentive to reduce 30-day readmissions. And I think each one of these projects had like a 30, 40% reduction, in readmissions. Like, in other words, we could do it repeatedly again and again because you could go and study, why are people coming back? What's the cause? What's the root cause? Why is that happening? And what can we do about it? There's always something actionable. There's always something that we could do about it. If I was going to throw one other example out there, I'll choose a story for a very specific reason, and it's a story that was driven by a nursing leader named Rebecca Trotta, because it was in this category I call paradigm shifts, which I think are actually important. This idea of length of stay, which is really taxing a lot of systems, that people are sicker and they're in the hospital longer, and care is so complex that these hospital stays can be quite long. The paradigm shift that Rebecca led was going from the model of finish care and then discharge to discharge and then finish care. So it was really just a flip, right? Instead of finishing care and then discharging, let's actually discharge and then finish care, right? So stabilize the patient. In those last day or two, maybe the things that you're doing, they're still critical to care, but maybe they don't need to be in the hospital for those last few things. And she implemented this for a very vulnerable population. This is a geriatric population. People on average are on 15 different medications. They were, in their 80s. They were medically vulnerable. They were socially vulnerable. And the fact that Rebecca cut more than a day off a length of stay and reduced, readmissions and emergency room visits by a third, it's remarkable, because that's a population where, like, these people are just so sick. There's no way that an intervention is going to work. And yet, by a lot of amazing work, it did work, right? And so I think that the punchline is that, these kind of dramatic changes are possible, but they require support all around. That was so many different clinical and also functional partners, engaging to change things. Wow, it's just not easy, right? So you have to understand that if you're going to change healthcare, it's not a simple snap your fingers solution. It's a deep investment of time and study and getting shareholders on board, and sort of storytelling and encouragement and not taking no for an answer. So, those are the stories that sort of stick with me, the people who just persevered after they hit the first obstacle and the second and the third and the eighth and the 14th. And they just said, this is too important, I'm not going to stop, and they tended to succeed, but it took quite a bit of time and quite a bit of effort.
Well, Roy, thank you for coming to the 5 Mile Difference. Really enjoyed our conversation.
Hey, Joe, it's always great to talk to you. Thanks for having me.
Thank you.